Good morning or afternoon or wherever it might be where you all are. My name's Dr. Barambi. I'm one of the consultant neurologists at the Walton Centre, and I'll be helping facilitate this session. We're going to get started in a couple of minutes, but before we start in earnest, I'd just like to introduce Professor Ben Michael, who just has a few words to say about this platform before we get underway.
Brilliant, thanks very much. Well, welcome everyone. We always start a couple of minutes after the hour just to allow people to join, because people are joining from all over the world. The background to all of this was that COVID was a catalyst that brought together a lot of people in the neuroscience community across the spectrum of neurosciences and allied professionals that see patients affected with brain complications of infection. And it really has been a catalyst, not just to bring us together, but to form this platform, which is a global clinical exchange platform, which allows us to all come together from all across the world. So if you would like to pop where you're from, your name and where you're from in the chat, that would be great. It's always exciting to see where people are joining us from. We are very thankful to the Policy Support Fund and the WHO who have helped fund this whole project, which has made the whole thing possible. And I'm delighted that we're joined today on the panel by Dr. Nicoline Schiess, who's an officer for the World Health Organization's Brain Health Unit and has been pivotal to the success of this whole platform. And also delighted that this month our chair is Professor Alla Guekht, who is the director of the Moscow Research and Clinical Center for Neuropsychiatry. She's a professor. She's also leading the Russian National Research Medical University, a treasurer for the International League Against Epilepsy, a trustee for the World Federation of Neurology, and co-chair for the Neuro Forum of the working group of the post-COVID complications, which obviously, as we're all aware, is a huge problem. And delighted to be hearing today about COVID and what it can do to the brain with regards to seizures and epilepsy. Over to you, Professor Guekht.
Thank you very much, dear Professor Michael, dear colleagues. It's really a great pleasure to be here, and many thanks for the introduction, for the invitation. I'm really grateful to the WHO Brain Health Unit represented here by Nicoline, and it was really excellent to assemble this Neuroforum, and we learned a lot, and we were able to actually to become friends and colleagues and to interact and to join our forces in the investigation of mysterious disease called COVID and its complications. So I'm very happy that today we have an excellent faculty, and we would never be able to find better speaker in terms of seizures and post-COVID and epilepsy and post-COVID than Professor Ali Assadi-Poyoar. Professor Ali is one of the leading epileptologists in this field. He is professor of epileptology and director and founder of the Shiraz Epilepsy Research Center. And he is also the director of Shiraz Epilepsy Care Unit and Epilepsy Surgery Program in Shiraz, Iran. And also Professor Ali is the adjunct research associate professor of neurology in Jefferson Comprehensive Epilepsy Center in Philadelphia. Professor Ali Assadi-Poyoar is the author of more than 300 papers, and the series of papers are dedicated to seizures and COVID and epilepsy. And also together we have an eminent panel member, Professor Shanez Tricky. And Professor Sharif Tricky is a professor of neurology in Tunisia, University of Sfax. She actually established the postgraduate training program in child neurology. And currently she is the head of child neurology department and director of medical research department. Also, Professor Shanez is very well known as Professor Ali internationally. She chaired the Eastern Mediterranean division of International League Against Epilepsy in the previous term, and currently she is the member of several councils, including the standards and best practice standard of the Council of the International League Against Epilepsy, and she's a very eminent board member of the International Child Neurology Association. So once again, today we will discuss mysterious and not well recognized phenomena of seizures in COVID. And there were a number of very contradictory opinions whether seizures are more prevalent in people with epilepsy with COVID, or COVID is, or epilepsy is a kind of the protector, so-called factor. And are people more prone to have more severe disease? And what happens with mortality of epilepsy patients? And also, what was the impact of the disruption of care? And we will address not only epileptic seizures, but functional or pseudo seizures or dissociative seizures. And I'm very much pleased to ask Professor Ali Assadi-Poyoa, who I'm already introduced, to give his talk that I'm sure will be really fascinating, and all of us will definitely enjoy his talk very much. Ali, the floor is yours.
Hello, everybody. I'm very delighted to be here, and I would like to sincerely appreciate Professor Guekht for the invitation and other colleagues at WHO for organizing this webinar. And I'm humbled by the introduction. Thank you very much. It was very nice of you. So if I can share the screen with you. You already have my screen, right? Or I have to share it again?
If you could share it again, yes, please.
So do you have it?
Yes, we can see it now. Thank you.
Okay. So these are my disclosures, and none is related to the talk. I have received nothing for the talk and for the research that I have done in the field. As you know, COVID-19 affects multiple body systems. And for years, we already knew that coronaviruses have neuroinvasion and neurotropism. They like to invade the central nervous system. Furthermore, patients with severe COVID-19 have hypoxia, have multi-organ failure, have metabolic derangements, and many of them require sophisticated therapeutic interventions. So it is plausible to assume that coronavirus, COVID-19, has association with seizures and epilepsy because they have interactions with the brain, which is the primary organ involved in epilepsy and seizures. So I'm trying to address some of the most important questions around the topic of interest. This is the first question. Are people with epilepsy at higher risk of COVID-19 transmission? So you have, I think, a polling system. I would like to invite you to answer to this question. Are people with epilepsy at higher risk of contracting COVID-19? So far, we have one answer only. Please, everybody, try to answer the question. Are people with epilepsy at higher risk or not? So 76% of the people said no and 24% said yes. And my answer to the question is that people with epilepsy are not at higher risk of COVID-19 transmission. So there are multiple studies in the literature. Some of them are confusing, and I can understand why 24% of the people said yes to the question. In one study, we surveyed people with epilepsy in comparison to healthy individuals and people with psychiatric comorbidities. And there was no increased risk of COVID-19 contraction among patients with epilepsy. In another population-based study, risk of COVID-19 was studied in more than 200,000 people. 1.8% of them had epilepsy, and the likelihood of having positive PCR test for COVID-19 was not higher among people with epilepsy. And to be honest, there is no plausible biological reason to assume that people with epilepsy are at higher risk of contracting viral infections including COVID-19. To the best of my knowledge, there is no evidence that people with epilepsy are at risk of influenza or other coronavirus infections or any viral infection. So we can be sure that people with epilepsy are not at higher risk of contracting COVID-19, despite the fact that you may see contrary reports in the literature. Let's go to the second question. Are people with epilepsy at higher risk of severe COVID-19 if they catch COVID-19? Is it going to be more severe in people with epilepsy? Yes or no? So here we are talking about severity of the illness in people with epilepsy. Again, I encourage you to participate, please. And the results. So half and half almost people believe that people with epilepsy are at higher risk of severe COVID-19. It is compatible with what you see in the literature. It means that the audience are very knowledgeable and they are reaching out to the literature with their questions. So it is controversial in the literature, very controversial. Some of the studies consider hospitalization as a marker of COVID-19 severity. And those studies concluded that risk of hospitalization is higher among people with epilepsy, and therefore risk of severe COVID-19 is higher among people with epilepsy. But other studies, including ours, we studied about 38,000 people, but we considered the need for intubation or ICU admission as markers of severe COVID-19. And interestingly, the risk of intubation and the need for ICU admission was not higher among people with epilepsy compared to other people. So it depends on what you define as severe COVID-19, and that is an area that we need more research. If you consider hospitalization as a marker of severity, yes, people with epilepsy seems to be at higher risk. But if you consider other markers, probably not. And interestingly, even those studies who considered hospitalization as the marker of severity concluded that risk of death, mortality was not higher among people with epilepsy compared to other people. So if the severity is higher, why isn't death rate higher among people with epilepsy? That is an unanswered question. I personally don't think that hospitalization is a good marker of disease severity. Because if a person comes to emergency department with COVID-19 and they gave you history of epilepsy, they may be considered at higher risk and be admitted to the hospital because of the preassumption of having epilepsy as a risk factor. Despite the fact that if they didn't have epilepsy, they wouldn't be admitted. So I personally, again, don't think that hospitalization is a good marker of disease severity, and we should rethink the research strategy to answer this question. I would vote no. The next question. Does COVID-19 affect seizure control status in patients with epilepsy? So if the patient has epilepsy, does COVID-19 affect seizure control status? Yes or no? Again, I encourage you to participate, please. And the results. Almost half and half. So some people believe that COVID-19 affects seizure control status. Some others believe it doesn't affect it. And that is, again, very interesting. Because the literature is very controversial, again, on this. So there are two types of studies. Some of the studies, including one of ours, investigated the natural history of seizures before and during COVID-19 pandemic in the whole population of people with epilepsy. Meaning that we selected 200 patients, 100 patients with complete seizure freedom before the COVID-19 pandemic, and 100 people with uncontrolled seizures before the pandemic, and followed them during the pandemic. About 30% of patients who had controlled seizures and were seizure-free had breakthrough seizures during the pandemic. But interestingly, about 30% of those who had uncontrolled seizures before the pandemic were seizure-free during the pandemic. So if you study the population of people with epilepsy, you may conclude that it is the natural fluctuating course of epilepsy, and COVID-19 does not affect seizure control status in people with epilepsy. But on an individual level, when you investigate individual patients with epilepsy, there are so many reasons to believe that COVID-19 may affect seizure control status. First, the lockdown due to pandemic may have caused poor drug adherence. Second, the illness may cause fever, which is a known risk factor for breakthrough seizures in people with controlled seizures. Hypoxia and neuroinvasion. Neuroinvasion causes seizures in healthy people, so why shouldn't it do the same in people with epilepsy? So on the individual level, it is very reasonable to assume that COVID-19 may affect seizure control status. But when you put these two types of studies together, you may come to the conclusion that yes, it affects the seizure control status, but it is not very concerning. It is not a huge impact. So if I want to answer that question, I would add a third choice that yes, it might affect the seizure control status, but not to a significant level. There is another important issue, that management of COVID-19 in people with epilepsy is probably a little bit different than management of COVID-19 in other people, healthy people. And it is more complicated. Why? Because patients with epilepsy receive anti-seizure medications, anti-epileptic drugs. And many of anti-seizure medications have significant drug-drug interactions with other medications, including those used to treat COVID-19. In addition, COVID-19 may affect heart, liver, kidney functions. So we might need to adjust anti-seizure medications in people with epilepsy who have severe COVID-19. And that is a very important issue. We can elaborate on that more during our questions and answers. So I go to the next slide, and I present to you another question. Should people with epilepsy receive a COVID-19 vaccine or not? So should people with epilepsy receive a vaccine for COVID-19? Yes or no? And the results? Absolutely yes. So thank you. Why? Because studies have shown that vaccination against COVID-19 is well tolerated and safe as other people in people with epilepsy. So it might have adverse effects, but the adverse effect is not extraordinary or unexpected or more than that in other individuals. So there is no reason to deprive them from COVID-19 vaccines. But there are many reports in the literature that have shown people with epilepsy have more vaccine hesitation compared to other people. Vaccine hesitancy and dislike for receiving COVID-19 vaccine is much, much higher among people with epilepsy compared to the general population. Because we as experts haven't provided them with enough information. If you search the web, organizations such as International League Against Organization, International Bureau of Epilepsy, or Epilepsy Foundation, or even WHO, there are frequently asked questions for people with epilepsy. But we specifically ask 500 patients with epilepsy, what are your frequently asked questions? And interestingly, we observed that we haven't provided answer to some of their important frequently asked questions, such as, does my anti-seizure medication have interactions with COVID-19 vaccine? What are the indications for COVID vaccine if I'm pregnant, if I am an elderly, if I have kidney function problems? So we have to address frequently asked questions in people with epilepsy, and I suggest in any group of people with chronic medical illnesses, by knowing their true frequently asked questions. It is not good enough for us as experts to assume what the frequently asked questions are and then provide the answers to those questions. We have to go to the public, ask them what your frequently asked questions are, and then provide the answers. So now, to change the presentation a little bit, I present a case to you. A 46-year-old man with severe COVID-19 requiring hospitalization and one tonic-clonic seizure lasting for 2 minutes comes to the emergency department. He has no past history of any significant medical issues. So he is not a patient with epilepsy. He doesn't have any other chronic illnesses. He had COVID-19 and one tonic-clonic seizure lasting 2 minutes. His weight is about 98 kilograms. Respiratory rate is about 38 per minute. O2 saturation is 80%, and he has decreased level of consciousness. So what would you do? How do you treat this patient? This is called a de novo seizure in a previously normal individual, which has a precipitating cause, here COVID-19, and then a seizure. Seizure is not a common manifestation of COVID-19. It happens in less than 1% of patients who require hospitalization with COVID-19. So it is not a common manifestation, but it is a significant issue. There are many reports in the literature of new-onset focal seizures, serial seizures, repeated seizures, and even status epilepticus, convulsive or non-convulsive, in patients who develop severe COVID-19. And potential reasons, as I mentioned before, are hypoxia, metabolic derangements, organ failure, brain damage, and the medical interventions that we do in patients with severe COVID-19. So how do we treat them? In any patient who has COVID-19 and seizure, you have to, I can't say you have, you'd better start an anti-seizure medication. It is an expert opinion, so it is the lowest level of evidence. So it's better to start an anti-seizure medication because we don't want to see prolonged seizures or repeated seizures in a patient who is already severely ill. It may complicate the management process. So I would suggest, I would recommend, strongly recommend, based on expert opinion, to start an anti-seizure medication. This anti-seizure medication should have some characteristics. First, it's better to have IV formulation because the patient is already sick. And we want to introduce a loading dose of an anti-seizure medication. Second, it should have as little as possible drug interactions with other medications. So we should select an anti-seizure medication with less possibility of drug interactions with other medications, because this patient is going to receive many medications for COVID-19 and the associated complications of that. Third, this medication should not affect major organs directly. So should not have cardiac issues or hepatic issues, because COVID-19 may cause cardiac problems and hepatic issues. So probably levetiracetam or brivaracetam are good options to select in patients with severe COVID-19 and seizures. We can give them a loading dose of 1,000 to 3,000 of levetiracetam and start a maintenance dose of 500 milligrams twice a day, depending on the kidney function. How long do we continue the medication? It was a precipitated seizure. It was a provoked seizure. It wasn't epilepsy. So we continue the medication as long as we think there is chance of severe disease. In patients with COVID-19, it is at most about 6 weeks. So I would suggest to continue anti-seizure medication for 6 weeks and then taper and discontinue the medication in a couple of weeks. So we don't have to continue the medication in a patient who had COVID-19 and one seizure or a couple of seizures for a long time, for 6 months or years. Just 6 weeks would be enough. Again, as an expert opinion. I think we are going to have a lot of questions on the novo seizures in COVID-19 during the discussion. And I would be happy to answer any questions if I can. And the last but not the least is COVID-19 and functional or psychogenic seizures or dissociative seizures, or please don't say that, pseudo seizures. As you know, functional seizures are oftentimes associated with psychological problems. And COVID-19 pandemic, not the illness, just the pandemic, has caused significant psychological problems for everybody, for ordinary people, for healthcare professionals, for politicians, for everybody. So it is plausible to hypothesize that the pandemic may affect the characteristics of functional seizures. It is plausible to expect to see patients with functional seizures coming to emergency departments, and we have to be aware of this condition. We have to be aware of the red flags for functional seizures to differentiate them from epileptic seizures, to manage the patients appropriately. In one study, we investigated patients who presented during the COVID-19 pandemic with functional seizures or before the COVID-19 pandemic with functional seizures. And there were semiological differences between these two groups of patients. Patients during the COVID-19 pandemic had less often had generalized motor seizures and had more frequent seizures. So the pandemic may affect the semiology because it affects the brain probably in different way compared to stressors before the pandemic. So this is another interesting avenue for further research on the topic. This is the end of my talk, and I'd be happy to answer any questions. Thank you very much for your attention.
Thank you very much, Ali, for the fascinating talk. Really, I think we all learned a lot. And while we will be waiting for questions from the group, I would start with a couple of questions, if you allow.
Sure.
And this pandemic was a disaster for all the mankind. However, I think in epilepsy, we might leverage of some lessons from pandemic. For instance, development of telemedicine, distant reading, and coming back to your question, actually, indeed, there was an increase of seizures in patients with epilepsy during the current pandemic, or hopefully the pandemic that already is finishing. But what are the lessons that we should learn and which are most relevant for epilepsy? The question to you.
So thank you for the question. It is an excellent question. Yes, it showed us that we need to boost telemedicine for everybody, everywhere in the world. Because this pandemic just highlighted some of the pre-existing issues that for years we ignored. One of them is access to medicine. There are no epileptologists or even neurologists in many places in the world. And people with epilepsy are oftentimes forgotten. But with the help of telemedicine, we could deliver care to them and don't expect them to come to the specialized centers to receive the care. So that was very important lesson for everybody. And for that, everybody in the world should have a safe and secure internet access. and the infrastructures for telemedicine. So I think politicians in the world, with the push-up scientists in the world, should make it an absolute right. The access to internet is a right for everybody. And the second lesson that I think we should learn from the pandemic is for people with chronic medical illnesses, including those with epilepsy. We shouldn't take it as granted that access to medication is immediate. Other problems could happen: disasters, hurricanes, earthquakes, wars, conflicts, pandemics. So people with chronic medical illnesses who need to receive daily medicine and daily care should have a supply of medications at home for a few months, and the government should have enough supply for them for some time. They shouldn't think that the access is just granted for everybody at every time. And I think these two lessons are very important, and we have to think about them very seriously.
Thank you very much. Awesome, Ali. And we have a question from our friend and colleague, which we both of us know, Dr. Betül Baykan from Turkey. And you can see her beautiful photo, and now we see her. The question is, what is the level of evidence about long COVID in people with epilepsy, and especially in children or elderly? I might start just a couple of facts. In the paper that we published in our post-COVID working group, 12% of people with post-COVID got seizures, developed de novo seizures. So that's quite significant, but I will ask Ali to comment.
Sure, the level of evidence based on the definition of the criteria for level of evidence is low, but it is very convincing because, you know, about 1 to 3% of people with severe COVID-19 may develop stroke or cerebrovascular problems. So they are at risk of developing post-COVID epilepsy. And COVID as coronaviruses have neurotropism. So like any other CNS infection, they may cause long-term problems, including epilepsy. There are case reports in the literature, there are case series in the literature, there are small studies in the literature. So the level of evidence is not high, but it is very plausible to assume that people with severe COVID-19 might be at increased risk of epilepsy, but the risk is not huge. We know that because we have millions and millions of people with COVID-19. If the risk was significant, we should have noticed that. So the fact that we don't have large studies in the literature tells us that the risk is probably not huge, but I strongly believe that it exists.
Thank you very much, Ali. May I ask Shahnaz to comment in terms of children?
Yes, thank you, Alla. And thank you, Ali, for this comprehensive talk. I would like to add some comment about the epilepsy. And I think we needed to make a difference between different syndrome, because perhaps the majority of study were done with adult person. And I think with child with epilepsy, with epileptic encephalopathy, and with severe syndrome, I think we can have different percentage and different reason, because already these children are very very fragile, if I can say that, for the epilepsy. And example, in our department, the number of children with COVID during the acute phase and also after the acute phase, we have epilepsy, we have seizure, because we have several other factors who can explain epileptic seizure in this group of patient, and mostly the fever, the elephant or the fever during the acute phase. So I think we need to have more study in children. Unfortunately, now we have a very few study about the children and about neurological symptom and epilepsy in children. But I think we need also to think and to differentiate the different syndrome, and to have in our mind that according to the syndrome and according of if the epilepsy is idiopathic or intractable or epileptic encephalopathy, we need to have different management and different thought about treatment. I think. What do you think, Ali?
That was excellent point, really. And it is absolutely true, and I completely agree with you. We know that for Dravet syndrome in children, severe myoclonic epilepsy of infancy or Dravet syndrome, fever is a significant precipitating factor for seizures. Yes. So we should expect more seizures in a patient with Dravet who develops COVID-19. And in patients with autoimmune epilepsy, we give them medications to suppress their immune system. So they have compromised immune system already. So the presentations, the severity, the mortality of COVID-19 in a patient with autoimmune epilepsy who is receiving immunosuppressant drugs might be different. We don't have enough data on that. So we should do research. Epilepsy, that's the point. Epilepsy is not a single disease. It's not a single condition.
Absolutely.
Epilepsy is the end manifestation of many brain disorders that have a common symptom or semiology of seizures. So a patient with cavernoma and seizure is different from a patient with autoimmune epilepsy and seizure, is different from a patient with idiopathic Jaundice epilepsy and seizure, is different from a patient with Lennox-Gastaut and seizure, from Dravet syndrome and seizure, from metabolic disorders and seizures. So studying patients with epilepsy is really not the best way to answer those questions. As you said, we have to be syndrome specific to provide reasonable answers to the many unanswered questions we have in the field.
Thank you very much, Agnes. Thank you very much, Ali. We will just have one question from the panel and one question from the chat, if you agree. So, Professor Michael Benedict, our eminent host, the floor is yours.
That's very gracious of you. Thank you for a great presentation, Ali. I thought actually you raised some really important points about access to the internet, telemedicine, and access to anti-epileptic drugs. And we're a very global audience. And just in case anyone's missed it, I wondered, Nicoline, perhaps if you might want to speak to the WHO's Global Action Plan on epilepsy and neurological disorders, which I think really is seeking to address the important points that Professor Ali raised.
Sure, absolutely. So epilepsy is a universal global disease, and as you know, different panel members have mentioned, it affects everybody from different phenotypic or etiology, and so it occurs all over the world, men and female, everybody, and so it's a great disease to focus on in order to try and deliver treatment, diagnosis, and care for other neurological conditions. And so our recently approved intersectoral global action plan on epilepsy and other neurological disorders does exactly that. So one of the pillars of the action plan is to try and harness the services for epilepsy and the diagnosis, the treatment, the care, the medication, the stigma. All of these issues around epilepsy are really a great pathfinder to try and develop care and treatment for other neurological disorders. So really, epilepsy is universal, and it's why we've made it an integral part of the intersectoral global action plan. Thank you.
Thank you very much, Professor Benedict. Thank you very much, Nicoline. I'm more than happy being representing the ILE and the WFN to listen to you and, well, quoting that epilepsy, as we are saying, is an entry point, and it was specified in the Global Action Plan. So thanks a lot for highlighting it. And well, once again, and please read the IGAP Intersectoral Global Action Plan. It's really available at the WHO website, and it was really done for epilepsy and other neurological disorders. We did not know when under the WHO leadership, we hope on that it will have a COVID-19 implication, but it became more global. Actually, non-existing conditions also fit within the IGAP. Okay, thank you. So we have another question from the chat, also both to Ali and to Shahnaz. Children with intractable epilepsy, do they have higher risk for severe COVID-19 infection? The problem in our country, Indonesia, is that we have not had a COVID vaccination for children below 6 years old. So I think there are two questions: their susceptibility to more severe, to COVID-19 and more severe course, and the issue of vaccination. So Ali, would you start, and then Shahnaz will comment, will follow.
So if you look at the literature, if you study epilepsy as a whole, the answer to this question is probably no. People with epilepsy of any kind are not at higher risk of severe COVID-19 if you put the marker such as intubation or ICU admission. But if you have a marker of hospitalization, probably yes. But as Dr. Tricky said and others said, if we study patients, children with intractable epilepsy and Dravet syndrome, patients with intractable epilepsy who are on immunosuppressant drugs, we don't have answers to those kinds of questions. Hypothetically, yes, but we don't know for sure. And with regard to COVID-19 vaccine, I'm not the expert, but I think in many places in the world, children are not receiving COVID-19 vaccine yet.
Yes.
Thank you, Ali. Shahnaz?
Yes, for severe, I think for children, severe COVID in children with epilepsy can be explained by comorbidity rather by the infection, and especially for children with disability or with other epileptic encephalopathy. Yes, in this case we have in general we had a severe form, but it is explained rather by the background of children rather than by the infection. I think we need also in this situation we need to think about the syndrome and not only COVID and epilepsy, and it's different according to the epilepsy syndrome in children. Especially for children with epileptic encephalopathy, we can have severe, and we need, in some cases, Dr. Ali, we need more time to treat patients.
And now may I have a question instead of providing an answer?
Absolutely, please, go ahead.
So as a brainstorming, it came to my mind, so maybe we have to select a homogeneous population of children with epilepsy, such as those with Dravet syndrome or Lennox-Gastaut syndrome, and then compare the severity of COVID-19 to those who had influenza infection instead of healthy individuals or instead of other individuals, to see if COVID-19 poses a more risk, because that what you said is very important. Maybe it is the underlying problems such as cerebral palsy or lung dysfunction that put the patient at risk of more severe infection rather than the virus itself. What do you think?
Yes, I think it's a great idea to do, but unfortunately we needed to have a global study, because it's not too much Dravet syndrome or Lennox-Gastaut. We don't have a lot of patients with COVID. And especially for children, parents are very careful, and they say that during the COVID they didn't come to the clinic outpatient because they are afraid to have infection, because they know that the children are not very in stable condition. So it is really a great idea, but we needed to have a patient with this condition.
Excellent point.
Thank you very much, Ali. Thank you very much, Shahnaz, for the excellent question and the brainstorming. And actually, Shahnaz, you can learn a lot and get some ideas for your project in our post-COVID working group. So that's like
Absolutely, Alla.
another benefit of being
Yes.
in this program that is led
Absolutely.
by Professor Benedict and Guekht. So, excellent. Yeah, we got some more questions. And also, yes, our eminent colleague, Dr. Zuberi, is actually giving the answer to their question of impact of COVID in Dravet syndrome. So thank you very much, Samir. Thank you for this reference, and we will definitely look at it. Also, Shaknaz, you mentioned comorbidity, and that's, I think, extremely important. For instance, in our study that we just completed in our clinic, indeed, there was a trend to high mortality in people with epilepsy, but after we stratified for comorbidities, then definitely the mortality was similar. So the comorbidities indeed play a role, and epilepsy is highly comorbid to numerous neurological disorders. Absolutely. And also, interestingly, indeed, Ali, you mentioned seizures. And as you know, as all of us know, in post-COVID, about 20% of patients, at least 20% of patients, develop depression and anxiety. So in principle, there should be, as we all know, the bidirectional association between depression, anxiety, and epilepsy. There should be an increase of seizures and increase of pseudo-seizures. So perhaps we will find it in the populations when we follow these groups. And now we're coming to the questions, is there any connection between epilepsy and microglial cells in relation to COVID-19? So I invite Ali, Shaknaz, and all the panel members to answer.
To be honest, I'm not the best person to answer this question. I know that glial cells are important in epilepsy. So epilepsy is not just about the neuronal cells, but I have no information on its relation with COVID-19. So I would like other colleagues to answer this question, please.
Thank you, Shaknaz.
I'm not the best person to answer this question.
Professor Benedict, you know everything about COVID, and you are leading the unit, and you got a number of awards. So
I better answer it well then, Professor Guekht. So yes, so we know from post-mortem studies that the virus doesn't get into the brain in almost all patients. It doesn't infect neuronal cells or microglia, but it does affect the vascular endothelium. And we know that even though the virus doesn't enter the brain, it causes fairly widespread microglial activation and the formation of these microglial nodules where they interact with astrocytes. So that's a way of answering the question without answering it. We don't know what it means for epilepsy and seizures, but we know that microglia can be activated in a parainfectious pattern. And we know from other viral infections like herpes simplex virus that in turn can be the driver of brain inflammation that causes seizures in that condition. So it's plausible they have a role in COVID too.
Thank you very much. Thank you. Excellent. Now there is another question. Actually, the question probably triggered by my comment on seizures in post-COVID patients. So you had mentioned that 19% of people who had post-COVID had seizures. How long it was between catching COVID and having the seizures? Well, I will start and then Ali and Shaknaz will follow. Well, actually, that's the data from our study in our working group led by Professor Ettore Beghi. And actually, in the meta-analysis, indeed, about 20% of patients with post-COVID, so that's at least 3 months after COVID, they got seizures. We did not look at their latency, but the group was followed for 6 months. Currently, there are published data for 1 year and I would say 18 months of post-COVID. But I don't think anybody looked at the latency, and that's really intriguing because, for instance, for post-stroke studies, the duration of latency between the acute episode and seizure is one of the risk factors for refractoriness. We don't know whether these seizures are refractory, but it might be another point of interest to look at it. So thank you very much again for the question, and maybe Alla and Shahnaz would comment.
Yeah, I have nothing to add. What you said was perfect.
The question is in the chat. How long was the latency? How was the time between COVID and the seizures?
You answered it very eloquently. I don't have anything to add.
Thank you. Shahnaz?
Yes, absolutely, because in the post-COVID it's after 3 months, but we have acute, in the acute phase we have a seizure, and after that we needed to wait for 3 months to have post-COVID condition. So I think it's
Yeah, thank you, Shahnaz. Thank you, Alla. And most of the studies that we were evaluating were cross-sectional. So actually we could not, we don't know the latency so far, but we definitely will look at that. And we have another comment and another suggestion to look at the publication on cellular and molecular aspects about COVID in CNS. And it comes from our colleague Clarissa Yasuda. Thank you very much. We will definitely look at this publication and we will learn more about cellular and molecular aspects about COVID in the CNS. Thank you very much indeed. Other questions from the panel, or maybe probably, like, you know, you will help me. I don't see other questions from the chat. Any question? Oh, good.
Yeah.
Again, Dr. Benedict.
Oh, I think Nicoline beat me to it, so I'm happy for her to go first. Thank you.
I don't have much. I just wanted to add the caveat to Alla's explanation on seizure latency in post-COVID is that we do not, there is still currently no clinical definition of post-COVID or long COVID in children. So that I think that that's important to keep in mind is that that has not really not been clarified post-COVID in children yet. So if you're talking about seizure latency, I think we only have an adult definition.
Yeah, excellent, excellent. Thank you. You know, I'm an adult neurologist, so I apologize, but like, you know.
So may I add to that, please?
Yeah, absolutely. Yeah.
So we, in adults with post-COVID, we have arbitrarily, I would say, selected 3 months. But based on a couple of recent studies, we know that endothelial cell damage and immunological and inflammatory responses are going on at least up to 8 months after acute COVID-19. So I think definition of post-COVID would evolve in the coming months or a couple of years, because 3 months, the 3 months window is just arbitrarily, to the best of my knowledge. It was defined when we didn't have enough evidence. We don't have enough evidence yet, but there are a couple of studies, as I said, that there are processes going on in the body for up to 8 months that might have relations with many conditions, including epilepsy.
Thank you very much, Ali. And also coming back to their comment by Nicolin, actually, in some studies, epilepsy was considered to be a kind of a protective factor because the risk was considered to be lower, the risk of getting infection. But for instance, in our study, we saw that it was very nicely correlated with stigma. So unfortunately, people were just like, you know, locked, and it was a double isolation. I would say that, so it was really like unbearable. People were stigmatized, and in addition to all the other restrictions, they were just locked in their apartments, in their houses. And definitely they had lower chance to get COVID, but the quality of life decreased dramatically. Okay, so we definitely need to follow all the items of the IGAP and combat stigma. Well,
and on that, may I add something, please, again?
Sure, absolutely.
You are absolutely right, and you raise a very good point. And we as professionals, I think we added to the stigma. because we closed epilepsy care units, we closed epilepsy wards, and we deprived the patients from receiving the care they needed during at least the early stages of the pandemic. And that is another lesson that we should learn and be prepared for in the future. And we should define in different scenarios when delivery of care to people with chronic medical illnesses, including epilepsy, could be or should be disrupted, because we ourselves disrupted care for them, unfortunately. And we have to be aware of that for future problems that might happen in the world.
Thank you very much, Ali. Thanks. Many thanks indeed. We have 4 minutes left. So may I thank sincerely Professor Benedict and Greta and all the team for the invitation. Nicolene, on behalf of the WHO, her unit for sponsoring this program, and mostly Professor Ali Asadipoyo and Professor Shaknes Twiki for the excellent comments and presentation, and definitely Ali for your fascinating talk, really fascinating, and that was really fantastic. I enjoyed your talk very much, so I hope that everybody will join me in applauding you and all the panel for this fantastic event. And I promised to leave 2 minutes to Greta, but as I saw that Professor Michael Benedict raised his hand, you have 4 minutes for the conclusion and the comments that you asked. Absolutely, once again, many thanks to everyone who joined us. We really enjoyed talking to you, and thank you very much for your questions and comments. Thank you.
Thanks, everyone. Thank you. Perhaps if we could share the slide, that would be great. So, Professor Ali, do you want to add a quick last thing?
Yes, I just wanted to sincerely thank you and everybody from the WHO, the ILA, who invited me here to share the ideas, the information that we had. It was a fascinating session, and I sincerely appreciate it. And thank you, everybody. Thanks.
Yes, and thank you too, and thanks, of course, to all the panel members and, of course, Professor Guekht. And thanks for sharing this, Greta. So this is a slide. If you enjoyed this one, do come and join us next month on the 21st of October. Again, it's at 2 p.m. London time, and it's going to be a brilliant talk by Dr. Sundar Salusi, a consultant neurologist and specialist in movement disorders, who's seen a lot of movement disorders in the context of COVID-19, who works with us in the UK, joined by the speaker, who's going to be Dr. Nesta, who is a neurology lecturer from Burundi. So it's absolutely wonderful to have them with us. I'm sure we'll have an excellent presentation, just like we've had today. Excuse me. If you'd like to give us some feedback, that would be great. And if you complete the survey, you'll actually get a certificate of attendance for your continuing professional development. And the links for all of that are in the chat. So lastly, to close things out, thanks to our speaker, thanks to our panelists, thanks to our chair, and thank you all for joining us. And we hope to see you next month.
Thank you.
Thank you very much. And thanks again for the questions and comments. Thank you.
Bye-bye.